Efficiency Unlocked is hosted by two tech-savvy physicians and dear friends of mine, Doctors Adam Karu and Dale Gold, who are experts in using technology to automate routine tasks and increase efficiency in everyday and business life. Let's see what they have for us today.
People think that they had like regulatory capture and like Judy's in Obama's ear whispering shit. That's not how it went down.
That's our guest this week, Brendan Keeler, also known as the Health API Guy. We talk about Epic, interoperability, and the future of healthcare.
Hey, we're going to create this close partnership. You're going to co-develop with us to create the right APIs, and then they're released to the world. So ambient AI is an example of that. You see Nuance and Abridge as the two partners in this top level of the vendor services program, and Epic takes their tithe for that. They take some equity in those companies, which is weird for them, right? They're not acquiring companies, but they're taking some equity. You see that for a couple different use cases, but for most apps, those aren't even an option, because like Epic only wants to do those programs or offer those programs for things they're not going to do themselves, but they know they need top tier partners, next level integration to stay ahead of the pack.
Here's a little bit more about Brendan. He is a Portland-based practice lead for interoperability at HTD Health. He previously worked for Flexba, Zeus Health, Redox, and as obviously mentioned, Epic. He also serves as an advisor for Flexba, Eleon, Rivero, and Revel AI Health. He's the author of the Health API Guy, a newsletter deciphering the complexities of interoperability, APIs, and regulation in healthcare. Brendan, welcome to the NerdMD's Efficiency Unlocked podcast. We're super happy to have you join us today. And today we get the privilege of having both of us, which Dale and I always aren't available to do all of these together. So thank you for joining us today on the show.
Yeah, psyched to be here.
And Dale's here too, but he just didn't say anything right there, but he's lurking in the background.
Hey, Adam. Hey, Brendan. Happy to be here.
Yeah, awesome. So I think, one thing we always like to intro our shows with is to find out a little bit about the person that's on it too, because I think that kind of grounds, the conversation and how we kind of progress. But so we like to learn about people's kind of origin story. And I know you've shared this on other podcasts and things that you put out in writing too. But, I think if you kind of roll back to the beginning of this, if you can kind of start with how you found your way into healthcare IT, and how you ultimately landed at Epic at one of your, first destinations. But we'd love to hear that story.
Sure, yeah. I mean, I grew up as the son of a doctor and a nurse, a urologist and a nurse to be precise. And, always had a fun ducking around that as a kid. And then assumed I'd be in medicine. But as soon as I did organic chemistry, like, this ain't it. And I did went to Penn and did like an internship with some twin cardiologists and saw, sheep being opened up to do heart research. I'm like, definitely not it for me. And so assumed I wouldn't be doing that, went to college, got a computer engineering degree, needed to find a job out of college. And my friend said, hey, come on up to Madison, Wisconsin, work for this company, Epic. I'm like, okay, like the video game, company, is that it? And then they're like, no, EHRs. I'm like, what the hell is an EHR? But I went up there. Epic recruits a ton right out of college, and I had a bunch of buddies up there. I thought it was really cool. I thought, hey, if I'm going to do technical stuff, might as well be in healthcare. So I worked for Epic. I was EDI, electronic data interchange. So focused around Epic's being deployed. How are you connecting all the other systems that orbit it? Because people forget that even as people, hospitals shift to Epic, they're getting rid of a lot of systems because it's one big cohesive or semi-cohesive electronic health record. But there's lab systems and picture archiving, communication systems for images and patient engagement, you name it. And so connecting all those things was my job as part of generally implementations, but also on the support side. And so did that both domestically for a year and change, but mostly abroad in the Netherlands.
Yeah, I heard you mention that. That was, so I guess timeline wise, was this pretty close to when Epic started to roll out kind of more internationally? Is that around the time when you started?
Yeah, I started in 2012. And so you start to see meaningful use has kicked Epic from a player, sort of in the mix into kind of dominant because they executed really well on meaningful use. People think that they had like regulatory capture and like Judy's in Obama's ear whispering shit. That's not how it went down. Epic just said, oh, this is coming out. This is going to help all EHRs. So it's in our best interest to go and just execute on these things. But internally, we hated a ton of those, and the things that meaningful use required, like view, download, and transmits, a big one where it's this feature that like you technically can download a CCDA document, the summary of a document in the patient portal, or it was actually every provider should have this capability. No provider knows about it. Patients don't really use it, and most EHR vendors didn't like it. So that all of that to say, I think that there's this narrative out there that like Judy's like the political whisperer. I don't know where that comes from, because like that's so orthogonal to like that's so different than like who she is DNA wise. And yeah, so I got to work domestically as that started to happen. Got to roll that out to a number of customers, and then they said, "Do you want to move to the Netherlands?" And I'm like, "Oh shit, yeah! Like send me abroad." And so then doing that, but in an international context, and that was one of the first international areas for Epic as a result of the partnership with Philips, the failed partnership with Philips. But then now that's a big growth area international because they've sort of saturated the available provider market domestically.
Got it. Yeah, no, that's super interesting. And I mean, Epic, I think to a lot of people, like you were mentioning, there's some misconceptions, some things, truth. I mean, they're a big company. They've kind of obviously taken over a large market share of major healthcare organizations, and they're even branching out into smaller and smaller pieces now too. But do you have any story that you could share from your time at Epic, either abroad or there, that you think could be worthwhile sharing with listeners?
Well, I mean, there's just like, it's a funny cultural organization. So like, it's not one that follows all the rules of like, oh, you need to take money on, like certainly not the case. Oh, you need to acquire a bunch of other organizations. They don't do that. Never will, never have in either direction in terms of being acquired or acquiring. But every month we'd get together 10,000, 12,000, 15,000 people in Verona, Wisconsin, in this giant stadium, deep space, because like all of Epic is themed, like dragons and Star Wars and all sorts of different things. Well, deep space is their mini little stadium. Like you could actually have like a really sick play or concert there, and they would get us all together, and we'd have different presentations. It's pretty useful, except when you were abroad in the Netherlands, it had to watch it remotely at like 7 p.m. on a Monday. The one funny memory is that we're in there and we're just going through this sort of like the standard stuff. Like Judy's telling us how to pronounce Cogito, the reporting module, because it was very important to spend 13,000 people's time times 30 seconds, that much money to tell us that every time. And she goes and she just puts a picture of poop up on the projector, and she says, "Whose is this?" And everyone's just like, "What is going on?" And then she goes, "This is a dog's poop, and we found this, and because of this, you can no longer bring your animals into office." And everyone's like, "What? Like, this is crazy." And all of a sudden, we hear this voice, and this guy gets up. This guy goes, "Judy, I have to admit, that's mine." And this guy had gone up to one of the mics that were out there for this Q&A section, and he just grabbed it and said, "That's mine. I'm sorry. It was my dog's, and I take full responsibility." In front of 13,000 people. So I don't know what that says about the culture of Epic, but there's a bunch of oddities, a bunch of like fun stories. And it was just a good place to grind and learn healthcare and make some good friends.
Yeah, I feel like those connections you made there probably laid the groundwork for a lot of the things you've done since then, right? And moved on. And, we were just talking briefly that you're out in Portland. Dale and I are in Denver. Portland gets a significant more amount of rain than we do, but both great cities to live in. And I think, pivoting the conversation to, what really has kind of where you've spent the majority of your time is around this kind of interoperability layer, of healthcare, which, I know you've discussed on your Substack and other posts that you've made, but, let's talk about, a little bit of the current state and maybe into that future state as well. Because I think, I guess, how would you kind of describe where we are right now in our current state? Because I think that's important for people to understand.
Yeah, when I talk about this, I sort of frame it around like let's piece apart interoperability a bit, because it's sort of a catch-all for a number of things. The first is sort of what I worked on at Epic, which is how do I connect all the systems within my hospital, my organization, intra-enterprise. And so those integration problems are step one, because otherwise the enterprise doesn't work. And so that's existed for a long time. That's what I did at Epic. I then left Epic and went to work for Redox. And Redox helps sort of the other side of the equation. They help apps that sell to hospitals connect and scale across all the EHRs they may encounter, because each of them does it a little differently. And so got to see the other side of the same coin a bit, but neither of those are really interoperability. They're sort of just like connecting all the things that are in an enterprise. But interoperability is really about connecting between different organizations, different enterprises. So provider to provider, provider to pharmacy, provider to payer, all those interactions that are in the era before EHR and the era before software are done manually, via phone call or fax or a text or something. That needs to be brought to the digital era. That needs to be part of how we communicate seamlessly. And so interoperability in that lens is something I got to work on at the next company I went to, Zeus Health. And that was focused on health information exchange. So provider to provider, how do we allow for, seeing the data, just the comprehensive data for my patients? And so that's come a long way. So interoperability, if you break them apart into those different sub pieces, a lot of people focus on that health information exchange, just saying, can I see the chart for my patients so I don't have drug interactions or drug allergy interactions, so that I don't have to ask them about their prior visits or their prior diagnoses. And so got to work a little bit on that at Epic with the Care Everywhere module, but really got into it while at Zeus. And the state of it is pretty good. 70% of providers are participating in these networks, in Care Equality and Commonwealth. These are the big health information networks that allow for this exchange, that allow for the exchange of clinical data for treatment purpose of use. There's a lot of other interoperability problems to be solved that are just like orthogonal to that. So referrals, right? Like it's not just pushing data, or it's not just pulling data so that I can see that summary. It's saying, oh, I need to send someone outside of my organization. Do I have to have a phone call? Do I have to first call up the payer to get prior authorization and then send that? Those pieces of interoperability, there's a lot of them that aren't well deployed, that aren't well, that are still in the pre-digital era. And so I think of everything in a spectrum, each of these sub-problems, each interaction between different provider types, between payers, providers, pharma, all the players in healthcare. There's different levels of maturity for each of those interoperability actions. One that I think is apparent to all of us, and probably you guys know a lot about too, is e-prescribing. E-prescribing is ubiquitous now, right? Like you're hopefully not writing, unless you're working at like Ascension right now, like you're not writing on a piece of paper the prescription for your patients. You're just sending it via SureScripts, via these e-prescribing messages. And so like that's the fullest level of maturity, and that's the promise of interoperability, is that we get these things to the point where you don't even think about it. You're like, oh, I don't write it down. I don't use the piece of paper, the fax, the pre-digital workflow.
Yeah, I think the pharmacy one is such a good example, because I think even patients misunderstand how well it actually works. I know when I'm interacting with a patient, either virtually or asynchronously, they'll be like, oh, can you call in this prescription for me, to this pharmacy, because I can't use our internal system pharmacy today. And it's just funny. Like, I'm like, oh, I don't have to call it in. I just need to know the name and the address, and I just need to look it up, and poof, it'll be there within seconds, and I can confirm receipt, and I can get refills, when you need it from there too. So, no, it's a really good example. And I think what, I guess what I want in the future, I hope all these systems eventually catch up, and it just becomes, because I think, patients having to repeat, their allergies wherever they go, or have to repeat this constant stuff. And, short from, what I think Singapore did many years ago, where they gave all their citizens like a little smart chip card, that they could just plug in to a workstation that had kind of that basic kind of snapshot look. That was, their health information exchange, in that early step. But I think, if we can get to that future where more of these systems are much more seamless, back and forth, bi-directional, and seamless, where do you see, with your expertise and your history, where do you see, some of this stuff that's coming, like with TEFCA and other things that are coming in, like in the pipeline? But where do you see the kind of the future of kind of this interop really going in healthcare for both the clinical side, but also the patient facing side?
Yeah, if we just take that, so on the one side, we have things like referrals, just not digitized at all, right? On the other side, we have e-prescribing. In between is clinical data exchange for treatment purpose of use. So we've gotten to about 70% of providers, all of Epic, all of Cerner, all of Athena, all these EHRs participating in sharing across organizational boundaries. And so that private industry, Care Quality and Commonwealth, these partnerships have gotten us this far, but it's starting to fray. We're starting to see people, a lot of different groups that aren't providers, look at these networks and go, oh, I'm pharma. Oh, I'm life insurance. Oh, I'm, you name it. Somebody that's not a provider, not to have a treatment purpose of use, say, I can use that infrastructure to pull data. And that's not really what it was intended for. It's not what it's, there's a lot of risk there in terms of HIPAA puts the liability on the releasing organization. So provider organizations, there's a HIPAA breach notification possibility for releasing inappropriately across them as people try to reuse this infrastructure. So the promise of TEFCA and TEFCA is the Trusted Exchange Framework and Common Agreement. This big new initiative coming from the ONC, from the Office of the National Coordinator, is the government saying, hey, we're going to help provide the governance and the rules to allow for a greater, broader set of purposes of use. So that I, as a patient, may be able to use those rails, that infrastructure to access my data. So that, those use cases I just mentioned, life insurance and in pharma and other things with appropriate consent and identity proofing can participate. And so it's to drag those new purposes of use from kind of working around the system and abusing the system into paved paths where they can follow the rules and achieve the business outcomes that they need. And honestly, that would reduce a lot of waste and problems if done appropriately with the right data protections. And the other piece is that hopefully TEFCA encourages the missing 30% of providers to join. So you have all the specialty EHRs, all the smaller, like kind of older, dinkier EHRs, because there's Epic and there's Cerner, but there's just tons of specific EHRs for obstetrics or behavioral health or PT. And they haven't joined yet. They haven't joined these networks en masse. And so getting the missing 30%, which a lot of times is really, really specific value in terms of you as a provider knowing the obstetrics history or the oncology history. Come on, that's what TEFCA promises. And that's what we honestly need, is to fill in the gap to get from 70% to 100%.
No, great summary. And I think that was, we haven't talked about TEFCA yet, I think, on the podcast at all yet, but we're taking that opportunity with you. And I think, shifting even further now from kind of like where you started at Epic, stitching together the organizational pieces to the interchange of those pieces of information. There's also another aspect, and I'll pass it to Dale for this, but, now we're going to talk about the kind of APIs, or the ways that people can plug in to larger systems like Epic or other EHRs. And so, Dale, why don't you take this one?
Yeah, I think that it might be interesting to hear kind of your perspective, where you started, piecing these for implementations. And I've done a lot of big implementations these last couple of years, so I know exactly what you mean. That's probably the most difficult and surprising piece, of our integrations is our go live and implementations is, these pieces we didn't know were plugged in, and will they continue to work? Will they not? And that team that does that is always in high demand, and that's a difficult pathway to build. But over time, I don't know exactly when you left and when you started, but there was, of course, in Epic, the App Orchard and that's progressed to partners and pals, and I think we've even changed to the showroom. But can you give some perspective on like where we started in that, and why you think it's changed, and why it's such a moving target based on your Epic experience?
Sure, yeah. So the history of integration at Epic, originally HL7 version 2 is the way that you exchange data between subsystems. And it was healthcare is laggard in a lot of things, but in terms of like standardized data exchange and coming to agreement about them, actually kind of like far ahead of a lot of industries. We do a lot of standards, probably too many. And so we had HL7v2. When I started Epic, that's what you used for 90% of the integrations. And it was okay. Like there was a standard, you followed it, you read the PDF, passed things back and forth. But with the advent of the internet, and you start to see APIs, application programming interfaces, become the dominant way to expose a clean contract of how I can interact with your system and retrieve different data or set different data. And so FHIR is a popular API format in healthcare now. It's the HL7's new standard. That shift is happening across the industry. In the background, Epic has always had some APIs. So not always, but since I started, proprietary APIs for communicating with MyChart. So MyChart communicates with Epic using these proprietary APIs, and making those available to potential applications was something that sort of sometimes you needed to do. You couldn't do something with HL7. You could only do it with these web services. So they stood up this program, App Orchard, and they let applications apply. And if you needed HL7 or if you needed FHIR, the new FHIR stuff, you didn't really need to use App Orchard. It's only when you need the proprietary APIs or direct Epic support as an app. And over time, it just got to be this bloated, weirdly configured app program by Epic. So they sunset it, and everyone's sort of like, what the hell? Like, what are you doing, Epic? Like, why are you getting rid of it? And so they could relaunch it, revamped as vendor services. And so vendor services is still a lot of the same stuff, but they want to make sure that they're tiering their support in a way that's commensurate with what you can expect for them. So if you just join vendor services, you can get support, you can get technical support and other things. If you have a special relationship with Epic, if you're doing a certain workflow they're not going to do, then you can join the next tier up. And you just have to follow the API for the weird thing that you're doing, like printing or something like that. And the highest level in this new showroom model is when they need to develop that sort of weird cutting edge integration for certain use cases. They're going to say, hey, we're going to create this close partnership. You're going to co-develop with us to create the right APIs, and then they're released to the world. So ambient AI is an example of that. You see Nuance and Abridge as the two partners in this top level of the vendor services program, and Epic takes their tithe for that. They take some equity in those companies, which is weird for them, right? They're not acquiring companies, but they're taking some equity. But as a result, you get this massive distribution advantage for these specific use cases because you're 3 months ahead or 6 months ahead of your competition in the Epic space. So you see that for a couple different use cases, but for most apps, those aren't even options because like Epic only wants to do those programs or offer those programs for things they're not going to do themselves, that they know they need top tier partners, next level integration to stay ahead of the pack, ahead of the EHR pack.
Can we double tap on the ambient AI? That's obviously something that we've talked a lot about, and Adam and I have done our part to try to figure out what the differences are. Clearly one of the biggest advertising differences is, integrated in Epic. Do you have any sort of take on that? I don't know how closely you follow that space with all the different AI clinical vendors, but what is your take on how to interpret that, or how would you speak to sort of a physician leader who's being told that, what are the smart questions to ask to really, understand what that really means?
Yeah, it's tough, right? Because you can be very much integrated with Epic and have a very different level of integration. And so those companies that are in the workshop at highest level so Abridge and Nuance, they have a really deep level of integration. They're going to be able to do things that their competition can't do or can't do for 3 months because they're co-developing stuff. And so it's taking a step back, like integrated should be like every system will need to be integrated. If it's not integrated, it's going to be a really shitty time as providers are copying things over to the EHR. That's like the bare minimum is no longer to have an integrated system for this use case for ambient. So then it just becomes like, I don't think about the integration. I think about the workflow. So like, what's the workflow they're portraying? And if they show that to you and it meets your business needs, then the integration is a how, is it achieving the how of what's promised. And so when purchasing a sidecar product like that, it's more about workflow for me. It's more about and other things like cost or, the other things that go into the business goals that you have. The integration is a how. And if they show workflow, they need to be able to back up the how with and say, we're able to do this because we have this level of integration with Epic. We've pulled notes out and we can send notes back in. We have smart data element, APIs we're using that fill things in the Epic chart discreetly. But those are all hows. And if the answer to the what is sufficient, then you're on the right track.
What would you say are the easiest? I mean, I know in your experience at Redox and, many places you've obviously worked and helped people get these APIs. Someone like me or Adam, we work on specific use cases where you learn about an API because you needed it for a project. But I don't really have a sense of, what's public and, what are the, bread and butter that some of these startups in different spaces should be able to get and should be able to offer those integrations, because those are not the complicated ones that need to be built, but those are the basic language that they could integrate, into their technology relatively easy on their own or with a partner.
Yeah. I mean, Epic's pretty good with this. Athena's also pretty good with this of listing the full set of like what's out there in terms of how can I integrate. So they have open.epic.com and fire.epic.com. That's like everything on those pages. There's no blockers. Epic's not charging them. Epic's not Epic. There's no, if they can go to a hospital, if an app can go to a hospital and say, hey, here's my workflow, then Epic's not going to stand in the way of that app and that hospital completing those integration points. The vendor services stuff, what's not there, is a bit more opaque, right? Because it's custom APIs. It's it's a variety of things. It's saving the photo of practitioners. It's some stuff for printing. It's really a random assortment. 99% of apps kind of don't need that stuff. They don't need the vendor services level APIs because Epic has so many inputs and outputs between the HL7 interfaces and the Fire APIs that you generally can get what you need done or satisfactory level of what's, for your MVP to prove something out from those, because you can get demographics sent out to you, orders sent out to you. You can write back in orders or results or discrete data or notes. And so there's really this broad set of sanctioned interfaces, public, APIs and interfaces to use for Epic. I think where it's more challenging is as you go downstream and look at EHRs that aren't Epic, because the further down you go, the fewer, there's less time they've spent building inputs and outputs because they're just barely keeping above water for the user interfaces, for the things that their users need. And so you go to like a Dr. Chrono and you've got a few APIs and you keep going down further and further, some of these specialty ones, and they're run on premise, they're, MS-DOS based or something, they're just really ancient and they may have like an ADT interface, which is just a simple way of sending demographics. So, people complain about Epic, but there's actually a lot of possibility to build if you don't fall into the trap. A lot of startups and apps fall in the trap of saying, oh, they're dominant, they must be dominant because they block me. It's like, no, they actually have a ton to build on and a ton of inputs and outputs. You just have to go take advantage of them.
Yeah, no, that's an excellent point. And we can link those pages. And I think that's what I've seen too, is that a lot of this, if you can think about the workflow and, what you need and what you don't and putting it right there, it can be done. Something else to kind of transition to is something that Adam and I probably talked about last year, but apparently you talked about, years before I even heard the words of a headless EMR. We sort of, as we opened our eyes to this AI revolution about what's possible. I really think of it as an ability to rethink how we as physicians, clinicians, users interface with the EHR, and what do we really need it for? What can it be? But then again, with your knowledge, you might have a little bit better understanding of, are we closer now with ambient in AI in general than you thought in 2021? Will Epic ever allow it? What are your thoughts now compared to then, and how close are we?
Yeah, I mean, so headless EHR is the concept, and headless anything like headless CMS for content management is something that sort of the idea of headless software came from. There's headless CRM for customer outreach. The idea is the user interface that the software provider has created is bad, and thus we're not suited for every user type if they're popular enough, and thus allowing people APIs to customize and build just different user interface, but funneling into the same backend. That's sort of the promise of like headless EHRs. Almost all headless EHRs that exist out there they built their user interface first, and they just have a robust set of APIs, of inputs, outputs. They're not truly headless in the sense that every data element, every possible action that's achievable through their UI, a developer can also use, but they're pretty close, or they're pretty robust. So there's a bunch like that. There are true headless EHRs. So MedPlum is an example of that, where they're a Fire server under the hood. They have some UI that you can use, but they're kind of expecting you to go and build everything on top of that chassis yourself. So it's not for the faint of heart. It's not really ready for like an inpatient setting. I think one of the things people forget about is Epic and even Cerner and like all these things that are in inpatient. It's a drastically different world than outpatient, where you can kind of like focus in on one specialty. There's a couple of workflows like note taking, e-prescribing, lab ordering, but there's a smaller set of for your MVP. Inpatient's a whole nother beast of just like Rube Goldberg machine, like the ER comes in, and then it could be sort of an outpatient, it could be sort of inpatient, it goes to cardiology, then there's ICU, and then you start to say, where's my smallest piece? And it's all interlinked within this one enterprise, especially in these mega enterprises, the Kaisers and the Sutter Health and all these giants out there, Providence. So the reality is inpatient EHRs, the headless EHR revolution is a little further away, but it doesn't mean that the API revolution can't be beneficial for people who want to build, who want to extend, who want to use new interfaces. And so, yeah, you see increasingly Epic, you go to fire.epic.com, we have a ton of available APIs to build on. And so we're starting to get there. It's not fully headless. I don't expect any of the inpatient EHRs to be fully headless and offer every input output in an API format in the next couple of years, but it's just a question of like, what do you want to do? And you probably can do a lot of it today. Yeah, like 100%. Like I think that we're going to like look back in, I'm going to say 10 years, and we'll look back in 10 years and be like, holy shit, what was this weird era in between? Because like back then, like you said, like we didn't have access to all the prior records, and that was a pain in the ass. And all the admin stuff was a pain in the ass. But at least we're just talking, right, as doctors and patients. And then we have this increasing wall of data collection, and like more data is better, and that means more burden and more typing. Like we're going to look at that era, and then we're going to be in this era where we're just talking, but we also have at our fingertips all the data, all the interoperability available from the 70%, hopefully in 10 years, 100% of providers and beyond, and everything else that contributes to health. So you can just say, wait a minute, hey, Epic Siri, tell me about a little bit more about what the recent vitals were from their Fitbit, and boom, you have it. I think that's like, I'm optimistic, but I think we're going to be much closer to that much faster, because to your point, this is a sea change. This is a dramatic rethinking of how we do everything. I think AI can be overhyped, but I also find myself using it for everything I'm doing and making myself much more effective in doing so. I imagine that moving outwards and encompassing all of healthcare. So yeah, I think how amazing would that be to be in that scenario where you're just talking to the patient, and you at the end of as they walk out, you go and you look and you say, yep, those are all the right orders. Okay, those are the right diagnoses. We're good to go.
Yep. No, I think it's a future that a lot are scared of and frightened, but also excited about, both on the clinical side and the consumer side. Well, this has been super fun, Brendan. I think we always wrap our shows with like what we call the Nerd Alert lightning round, a rapid fire kind of set of questions just to learn about you at the tail end. So I'm going to hit you with some of these, and if there's something that you want to pass on, you can as well. But first one up, do you have a favorite book or a favorite source of, where you like to consume your reading and information?
So I, for like work things, for businessy things, I don't really read a ton of business books. I read a ton of newsletters. So I read Health Tech Nerds is a great, newsletter and community. I read Out of Pocket by Nikhil Krishnan. Like that's a great, funny source of information. And there's been so many. I think a lot of the authors have kind of tailed off in like post ZERP, post like pandemic, like back then people had time, they weren't doing shit. And now they're, either they have kids now like me, or they have social life. Yeah, so like that's for business. For pleasure, I read a lot of sci-fi and fantasy. So I just like to escapism when I'm not thinking about healthcare and healthcare technology.
Yeah, no, that's great. It's always good to have something that outside that you can kind of detach from. If you could master kind of one skill instantly, what would that be?
Oh man, that's good. Yeah, I suck at instruments. I think it's not for a lack of trying, right? Like I tried cello, I tried piano, I tried all those things. That would be sweet. Also, like I speak 4 languages, but not really, right? Like I speak English very fluently, or semi-fluently. I speak Spanish, Dutch, and French, but like I've only gotten like 50%. And so I'm very jealous of my wife who speaks French fluently and all my friends who have just like native learning ability. But I'm on day 112 of Duolingo, so I'm going to keep it going.
Good job. No, and I think music, I won't speak for Dale, but I can definitely speak for myself. I feel like I enjoy music. I like listening to it, like a variety of it, but can't play it. And then there's folks in my family, one of my nephews, and he self-taught himself to play guitar, like no lessons, just used a combination of YouTube, some apps, learned all the different chords. And now the kid is like crazy. I mean, it's insane. So, it's definitely a different world now. I guess if you hadn't landed in healthcare IT, where do you think you would have gone, or where do you think you'd be?
I mean, like the opposite universe, like alternate universe, Brendan would have been in the military. I did Air Force ROTC for a couple of years, so I would have been probably in like Dayton, Ohio. I don't know, maybe be abroad. Probably still doing computer engineering. Maybe in like a missile silo out by you guys in Colorado somewhere. So who knows? It would be very different.
So still software, still tech, but could have been some sort of adjacent or totally different industry. Yeah, totally makes sense. What's the most daring thing that you've ever done?
I did study abroad in Australia, in Perth, Australia, which is about as far away from any other major city in the world you can be. It's closer to like Madagascar than it is the rest of Australia. But traveling back, which was cool, but like it was far. Traveling back, I did like all the East Coast travel of Australia, all of New Zealand, and in New Zealand we did like a double crazy day where we did skydiving and then we did bungee jumping off a bridge and like into the water of a river. So yeah, like check, not going to do those again. That was my daring day.
Yeah, especially after you start having kids, right? I heard you mention that. And I think things change. I mean, I had like either like a scooter or a motorcycle up until we had kids. And then I was like, nope, that's no longer worth the risk. So yeah, hear you there. Last kind of question, the spirit of this show around efficiency, is there, we love it when our guests like share some sort of tool or automation piece of software or really anything that they use to help kind of simplify their life or make it easier. Is there something that you couldn't live without if we said you had to give it up today?
Oh, For efficiencies, I mean, I'm kind of a basic bitch when it comes to this stuff, but like Gmail is my task list. And so the snooze, factor, the snooze feature is really, really important to it is how all of my work is constructed. So if I'm not doing it immediately, it's probably going on snooze or it's still on my task list. And so if that was to go away, 70% of the work that I need to do would just be lost to the void. And I'd have no way of knowing. Never come back. So yeah, please Google, don't get rid of that like you do all your features. I beg you, Google.
They're big listeners of the show, so you should be good.
Yeah. Totally true. Well, awesome, Brendan. I really, Dale and I really appreciate you taking time out to chat with us today. Hope you had a good time as well. But, I think your insights around this and kind of piecing together, this journey that we talked about today around kind of interconnectability, interoperability, technology, integration, and into the future was, a really fun conversation. Do you have any last closing words you want to end with?
I mean, thanks a lot for having me on. And if any of the listeners want to chat about this stuff too, you can find me on Twitter. I think now X, it's officially x.com today.
Officially,
so
yes,
it is. Happy X Day, LinkedIn or my Substack.
Awesome.
Yeah, thanks. It's so great to have you on. Go Birds.
Go Birds.
Yeah, dang Eagle fans. All right, cool. Have a good night. Thank you for listening to Efficiency Unlocked, Nerd Tested, MD Approved, a Nerd MD's podcast by Drs. Adam Carew and Dale Gold.